intellect, and an unwavering determination to succeed. Watching you grow, Varun, not just academically but also personally, it is a privilege for me. Today, as we stand witness to his success in the field of medicine and research, we are reminded of the power of persistence, hard work, and incredible heights one can reach when one is determined to learn and excel. Varun's accomplishments remind me that every student, please listen, that every student has potential and contribution to the field of every student has potential, and sometimes it is the quietest voices that make the loudest impact in the world. Varun's contribution to the field of osteopathic medicine and research, especially in his at Lake Erie College of Osteopathic Medicine, is a testament of his passion. I have gone through his CV. There are a number of publications on the subject for improving the healthcare and his commitment to making a difference in the lives of others. So now I will not take much time. On behalf of entire Titankar Mahavir College of Pharmacy family and students, I am honored to have him here with us today, and I am looking forward to hear more about his experience and the knowledge that he will share with us today. So I once again warmly welcome Dr. Varun Suthi. Varun, please, you can start.
Thank you so much, sir. I am sincerely honored with your kind words. I'm really touched. Thank you. Um, Today we're going to talk about the evolution and advancement in the field of multiple sclerosis with regard not only with regards to the diagnosis but also the treatment. We have come a long way, and I actually published a couple of papers in multiple sclerosis, including the first one that was right after the COVID, and a student of mine who is now matched into a neurology residency program. So he this year he graduated and matched. He had multiple sclerosis, and that was my first encounter with a patient, who was my student, who was highly functional, thank goodness, afterward. And he was the one who told me about that, how the life can be very challenging. Somebody who has multiple sclerosis, and he was in medical school, and he went through the medical school, went through his clinical years, rotations, and eventually now he's a neurologist. But that opened eyes for me, particularly into the field of multiple sclerosis, and we did some research. And during COVID pandemic, we found that there were so many patients who did not have any predisposing risk factors for any multiple sclerosis or any kind of neurological disorder. They also developed a new onset of multiple sclerosis. So imagine somebody who has no remarkable history of any sort of neurological conditions, and they, just because they contracted COVID, now they have a multiple sclerosis disease, which can be very devastating. So we're going to look at it, how it's going to go. So multiple sclerosis, how do you define multiple sclerosis? Well, sclerosis comes from a Latin word called sclera, which means plaque. And we all know what plaque means. I'm not talking about plague. I'm talking about plaque. So it means patches, hardening of neurons or hardening on the skin or hardening of any tissue in any organs. So multiple sclerosis means multiple hardened areas. This is a CNS disease, so it involves brain and the spinal cord. It's demyelinating disease, so it means the myelin sheath, which is there, which forms the protective covering of the axons in the neurons in the brain, they begin to disintegrate, they get destroyed. And not only the myelin sheath, but also the oligodendrocytes. If you recall from the neurophysiology class, if you ever had, there you will see the oligodendrocytes also play a very important role in holding that myelin sheath together. So that gets destroyed. Before we go further into a little bit, so let's assess for a moment what impact can it have. So if you break the myelin sheath, you can see the communication within the neurons, between the neurons, intraneurons, within the body, everything gets broken down. And how does it manifest clinically? Well, it can result in so many deficits, including the sensory, motor, and cognitive problems. Sensory, you all know it's self-explanatory. Motor, with regards to the ability to speak, to walk, to do day-to-day activities, and cognitive, because it's in the brain, so obviously you're going to have some cognitive deficit. Let's look at the pathogenesis. I'm sorry, can you hear me? I heard a commotion in the background, so if somebody has a question,
Yes,
please feel free to ask me. You can stop me anytime if you want to and ask question. So let's dive a little bit deeper here. Let's get into the weeds. What exactly happens in the process of the development of the disease? So we all know there's a blood-brain barrier. The barrier is protective, sort of a barrier between the CNS and the rest of the body, just like we have a placental barrier when you have a young developing fetus. Similarly, we have the protective barrier in the brain. So everything is very tightly regulated. Nothing can go past into the brain because brain is responsible for pretty much everything what we do. So the body or the nature or God, as you may call it, have a very strict mechanism for regulating of the molecules and the materials that go inside and outside of the brain. And typically, any willy-nilly, any infection cannot get into the brain. So it's if something has to go through, either there are carriers or mediators or receptors through which it can get through, or if the blood-brain barrier is compromised for some reason. So T cells, usually they do not get into the blood through the blood-brain barrier into the CNS. T cells are important in not only promoting the body's immunity, but also against pathogens or against infective invading microorganisms. So T cells, for some reason, in patients with MS, they get through the blood-brain barrier. Once they cross the blood-brain barrier, they get inside, and what they do, they immediately recognize the myelin sheath, as you can see here. Can you see my cursor?
Yeah.
Okay. So it goes there, it somehow crosses the blood-brain, so you can ask me, what are the situations in which they passes through the blood-brain barrier? Because typically they are not allowed. Well, if there's a breach, if there's a compromise, if there is some sort of breakdown of the blood-brain barrier, then the T cells can go through, and they recognize the myelin sheath here. Once they recognize them, they get activated. Once they're activated, what does activation mean? Well, it means they need more T cells. They call their friends, that I like to give that analogy. They call their other friends that, hey, I got here. When I can get here, you can come here too. Let's eat the brain. So in a layman's term. So now what happens? The endothelial cells in the blood-brain barrier, they begin to express more receptors for the T cells. And now more T cells are recruited and transported across the blood-brain barrier. Once that happens, the activated T cells, they stimulate a cytokine cascade. So more interleukins, different kind of interleukins, 1, 6, other inflammatory mediators such as TNF alpha, interferon gamma, all get activated. And in turn, they now relaxes the smooth muscles, vessels, which are lining the blood-brain barrier. And now T cells, macrophages, B cells, all of them can get inside the brain. So it's like you unlock the key and everything, then everything is now open, and whatever the inflammatory mediators which are there in the rest of the body, they can all come back inside your brain and can cause damage. What B cells do? B cells produce the antibodies, and those antibodies directly tag. Hear my word carefully, tag. They are not destroying anything. They tag the myelin sheath right here. Why do they tag it? They tag them, they highlight them that, look, this is the thing that you need to destroy. They give the signal to macrophages, and then macrophages comes and they destroy everything, as you can see here. Once that's the nature of the macrophages. They destroy it, and once they destroy it, that breakdown causes the formation of plaques. So it's all not doom and gloom in the beginning. Our body has a mechanism to heal and repair itself, which is also an important tenet of osteopathic medicine. The body has a capability to repair and heal itself. That happens. So we have regulatory T cells, which are regulatory T2 cells. They then come inside and they start the remyelinization process. So they start in kind of viruses can also uh, cause the blood-brain barrier breach, and as a result, can not only trigger multiple sclerosis but all other neuroinflammatory disease, including multifocal leukoencephalopathy. Just remember. So there are different types of multiple sclerosis. It's not that one patient has one multiple sclerosis, other patient has other. Multiple sclerosis in general is the same in principle, but there are different manifestations of it, depending upon the severity. So the most typical that we see in patients, which is easily controlled, and it's not a big, is the relapsing and remitting. So relapse remitting means you bout which is followed by months or years of no secondary episode. So you kind of recover from that. And eventually you will have another bout if you are not under the treatment, if it's not controlled, if you are not taking any treatment for it. And you improve, remember, remyelinization happens. But the problem is with every subsequent bout, you're not able to completely heal, you're not able to completely recover. And again, the next bout happens. So what there is a baseline buildup or accumulation of the plaque, and that directly related to disability index. So let's say if let's say a patient has about time, and now they're 6 months later, when they have another, even though they might recover, but their level, the cognitive level, the neurological status, the motor status, they change because something is damaged in the brain. So they might recover temporarily, transiently, but eventually they will, the damage keeps accumulating and piling together, and the gets to a stage where nothing has done. And unfortunately, it results in significant mortality rates. So that is relapsing remitting. We have a which is secondary progressive. In secondary progressive, it's pretty much in the very beginning, it follows the same pattern as relapsing and remitting one, but eventually there's no remyelinization. There's nothing. And the assault is too much, the patient cannot really recover after second or third bout of MS. And then it's just a linear progression from there on. So it's also a bad news. Then we have primary progressive. And I'm not talking about somebody who had just one episode and never nothing happened for the rest of the life. We call them clinically isolated cases. But there are significant number of patients who have primary progressive, which means they had episode, and from there is no repair, no remyelinization, and from lifelong, the things are gonna progress down the hill. It means it's gonna be significantly impacted unless and until they have treatment, which we're going to talk in subsequent slides. Things are very murky for them. We have the last one, progressive relapsing. So it is very aggressive, not as aggressive as primary progressive, because it also has some realization, but the base level itself is so high that it's difficult to play the catch-up game. So these are 4 different types of multiple sclerosis, not the type in a real sense, but based on the severity status, we categorize them into 4 different types. Relapsing, remitting, secondary progressive, primary progressive, progressive relapsing. And mind you, if you are a primary care physician or if you're a neurologist, the treatment varies. It's not the same treatment for all. Look at some of the common manifestations. So once we have about, it stays for about a week or a month or a year, but the symptoms can progressively worse.
है पता नहीं कब तक है
There's an echo on the other side. Okay, thank you, Isha. The Charcot's triad, that's what we call triad, means 3 different kind of symptoms. Here we are talking about 3 different categories of symptoms. So dysarthria, which could be related to difficulty in speech, unclear speech, And that results from the formation of the plaques in the brainstem area, particularly. Then we have intention tremor. So let's say it's a potential involved, as happens in the case of Parkinson's. You will have tremors, resting tremors, as you can't even walk sometimes. Some patients may develop uh, uh, dystonias and ataxia. They lose muscle tone, and eventually they paralyzed and can't really walk. Some patients also develop nystagmus, which means you lose the ability to control the eye. They go out of control, it becomes a problem. Let's dive a little bit deeper into that. So if you're talking about plaques in the brainstem, can cause significant problems, not only with your speech, but also very generic functions, such as eating or swallowing. Even swallowing, the patients can't, if the muscles are not working, they're not getting information from the brain. What's, you can't even swallow. You can't drink, you can't eat. Forget about talking. You cannot even do anything, the basic thing that you're supposed to do. It becomes very harrowing. And if there are intentional tremors, so it begins such as a normal shake of the hand or shake of the head, eventually progresses plaques all over the motor pathways, may result in quadriplegia. If it is happening in the eyes, so may have in the beginning some blurry, some loss of vision eventually, but they may also have double vision. Sometimes they develop pain, but it's usually optic neuritis. It can be nephropathy. It can be retinopathy. It can be blepharospasm, which means the twinkling of the twitching of the eyelids and inflammation in there, and you just can't really see. And it's not conjunctivitis or uveitis or cyclitis. It's the whole of the entire anatomy of the eye. So it's really dangerous. We're not talking about the inflammation here. We're talking actual damage to the anatomy of the eye. But it's not just limited to those Charcot symptoms. It can manifest all over the skin. And if it is happening over the skin, imagine if you have plaques all over the skin, what can happen? Some patients, they call it needle sensation. It seems like if somebody's pinching you with an actual needle. That is the sensation that described. So we call them pins and needle. Some patients may not feel anything on the end, they have numbness. Some can have tingling, itching. So we call them paresthesia. Some also report as if they're having some burns. So it varies. It's a wide spectrum of dermatological manifestations. Interestingly, which is very common, late stage, advanced stage, is the Lermit signs, which means the patients describe that they are as if somebody has shocked them with 1,000 volts. So they have electric shocks, which radiate down the spine, radiates down the. Um, I, I don't know if we have medical students here, but for pharmacy students, they maybe this information is redundant, but I will tell you that you have to distinguish it from myocardial infarction, because that's also a thing. If you're having a heart attack, myocardial infarction, or ischemia, you have the similar presentation. You have the presentation of radiate. If you are a male, the pain will radiate towards the heart. If you're a female, the pain will radiate towards your kidney or towards the lower abdominal area. So you have to do an ST elevation. You have to watch out for EKG findings on that. Here, you would not see any abnormal EKG findings. If the patient says, I have electric shock lightning, yes, the pain radiates to my arm. Rest, yes, the patient radiates towards my lower extremities or upper extremities. It means it's not heart related, it's probably neuro related. But you still have to do an EKG to findings. And then you can have plaques in your autonomic nervous system. And we all know it's there in pharmacology, it's there in physiology. Autonomic nervous issues, if you begin to have, then you will see bowel movements. You'll see bladder incontinence. It means you cannot control urination, you cannot control defecation. And patients may also experience dysfunction. And because it is us neurological things, you will see higher concentration power, such as if you want to think clearly or if you are trying to focus, you cannot do that. And if you're not able to do anything, whatever you do in a day-to-day life, what will it lead to? It will lead to frustration, it can lead to anxiety, it can cause depression. And in the beginning, you can say, okay, we can use antidepressant, we can use SSRIs, or we can use other drugs for depression, or we can use benzodiazepine, for example, for anxiety. They don't really work in patients who have MS. Yes, in the beginning it might work, but symptom management over long term, it's not going to work. So how do you diagnose? How do you diagnose MS? Well, in the United States especially, you cannot order an MRI right away, even though it is the gold standard. You cannot do it right away. You have to go through a proper workup because the insurance company called the shots here. So you have to do some blood work. And in the blood work, what you're looking at some antibodies, especially immunoglobulin G, which is indicative of a chronic autoimmune disorder. You have that, and then some physicians like to do what is called a visual evoked potential test. The stimuli, they show you a specific things, and they measure your responses. You're able to process through your brain. If those tests are positive, then a neurologist can for an MRI. Typically, we do not do with contrast the MRI, we do without contrast. Also, we can do with flare, without flare. Some people do with T2 MRI, but MRIs are very important here. Let's look at some of the key characteristics that you see on the MRI. First, I want you to just absorb this slide. Look at it and see what you find. It's adult male. We can clearly tell that. There is no widespread atrophy. But there is something which is very peculiar.
Gaps.
Can you see these things? So these are the ventricles, as you can see. So hydrocephalus
So
going
gaps
on.
like
That's
this.
why. Yes, those are the Dawson fingers. They are fingers like projections in the beginning. This is just a initial stage, so they are not predominant, but you can clearly see them still. And they're very specific. It's not a tumor. It's not an intracranial hemorrhage. It's not a subarachnoid hemorrhage because they look different. These are very specific for MS, multiple sclerosis. We see these Dawson fingers. I did the nomenclature for. There was somebody, some patient whose name was Dawson, and that's how it started. People say, "Oh, it wasn't the patient; it was a." Well, we don't know, but that's what the legend is. So these are Dawsons. Let's look at some other MRI images. This is with the that was with the flare. This is with T2 weighted. We are looking from the aerial view here, and you can clearly see the progression from baseline and how it progresses. Let me help you here a little bit. You can see the fingers here. Elsewhere, it's okay. You can see some atrophy here as well. And then upon subsequent episodes, you can see here, this is now damaged. So it undergoes atrophy, eventually becomes necrotized. You see that? And can you also appreciate the fact that these ventricles, they are enlarged now? Why they're enlarged? Because inflammation is going on there. Inflammatory mediators are there. That is why they're enlarged. And look how completely dilated they are. And it's much more damage that you can see. Just imagine what these patients are. You just simply cannot see patient as a number or as a person that you are seeing in the clinic. They are humans. So you always maintain that compassion and empathy. This is stage. Now look at that. My goodness. It is so devastating. Do you see? It's now more diffused. It's spread pretty much everywhere. And you can see how devastating it can be. Sometimes as physicians or as clinicians or as students on rotations or as residents, you tend to lose focus on the humane aspect of the medicine. You always have to maintain that. So that was all about the diagnosis. Up until now here, we talked about the general overview. We looked at the etiologies, pathogenesis, diagnostic test, including some key characteristic findings that you will see on the MRIs. Two different kind of MRIs can be done with flare, without flare, with the T2 weighted. Now we're going to talk about the evolution advancement of drugs. If you have to define multiple sclerosis in a nutshell, how can you describe it? It's an autoimmune condition, right? So our immune system, in layman's term, it's gone out of the whack. So we can give any immunomodulator drugs. In the beginning, back in the 70s and 80s, we had drugs such as cyclophosphamide. Oh my God, it will mess your body up. It will have devastating consequence on liver and on the kidneys, and it was just a bad news. And it would reduce, because it's an immune modulator drug, so it will reduce your capacity to maintain your normal immune. And if your immune system is suppressed, because that's what we are trying to do, we are trying to suppress the immune system so that the inflammation goes down and we can have some benefit for the patient. But in doing that process, you are trading with the opportunistic infection. So pretty much the immune status of the patients is exactly like those who have, let's say, who have undergone organ transplant or who have HIV. So, what happens to those patients? They can develop all kind of infections, everybody. But things gotten better since then. From 80s to 90s, in 90s, especially in 1993, the FDA approved interferon beta 1b. Interferon gamma, don't confuse the interferon gamma. Interferon gamma is the one which is pro-inflammatory. Interferon beta is anti-inflammatory. So it counteracts. So we have the drug, interferon beta. Eventually, we had glatiramer acetate. Then we had mitoxantrone, which was responsible for the seizing and stopping of the B activation. In 2000, we had our first monoclonal antibody treatment, natalizumab, which was very specific. But don't be fooled. If they're very specific target, it doesn't mean they are not going to cause. It can cause significant impact. But you have significant control of the symptom. You did not see relapses that much. So you were able to overall reduce all mortality. In 2010, we had breakthrough, another drug of its arrived, fingolimod. These are the drugs which are modulation of sphingosine receptors. I will talk about sphingosine receptors in a few minutes. Then we have teriflunomide, we had fumarates. The first of the fumarates came in 2013. Another medication which was monoclonal antibody, altuzumab, I think it's CD52 antagonist. In 2015, in the US, glatiramer acetate became generic. After the pharmaceutical companies had their share of greed satisfied, then they said, okay, you can have a generic version of it. It was good. And then we had in 2017 and 2019, up until we have different antibodies. Ocrelizumab was the one which is also CD20 antagonist. In 2019, we also had Cipamod, which is again a sphingosine receptor modulator, Droximil, and then in 2020 we had dimethyl fumarate became generic, and we had another antibody which is also active, by the way, ofatumumab. So these are all monoclonal antibodies, very specific. very high intense, they can immediately rest the situation under control. So this was the evolution and advancement. We will now specifically look into different drug categories and talk about some key features of these drugs. Talk about that. Let's assume you are a primary care physician. So what in India, a general practitioner, in the rest of the world, we call primary care physician. It's the same thing. A practitioner means anybody can go to them any disease and they are the first doctors. They're not specialist doctors, they treat pretty much everything. Primary care is the same thing. So if you have a patient who has, and if you see that they have some symptoms, what do you want to do? Don't panic. You can still treat them. Your first goal be to minimize the damage that you can. And remember, we are trying to control the inflammation, so we can begin with some steroids. Methylprednisolone, prednisone, and prednisolone both have been shown to be very useful, especially if you administer the first 3 days. They are actually stemming the flow of inflammation. So you don't have to panic if the new doesn't have time for the patient and there's a 1 month delay. You can start the treatment for the first 3 days with methylprednisolone, and that should give some immediate relief. But you should also combine that with an anti-epileptic drug because the patients may have some seizure accompanying symptoms. So such levetiracetam or phenol, things like that you can administer to control seizures. Benzos are given, but they are given in the emergency room. So they usually give IV. Status epilepticus, which can accompany these patients, by the way. So anything which you're giving IV, what you're going to have? You're going to have some infusion-related reaction. If you're infusing them, also is effective, and there have been studies conducted which that there's significant difference as far as patient outcomes are between the two different kind of dosage forms, and oral are equally effective with the control of the inflammation. But there are some safety considerations not usually seen with steroids use. They have MS, so patients can develop some mood disturbances and they may have some headache, have some insomnia. And if the patient is also diabetic or hypertensive, you make sure that you are covering for that. So that's how you do the acute management in a primary care setting. You can appreciate the table if you would like. It just of adverse effects that we treat with the use of these steroids in MS patients. As you can see, and they are comparing it with the IV, oral and IV. So it's not very significant difference. The significant difference, I think, is this one. Insomnia, as you can see, the p-value, the value is 0.03, so it has to be less than 0.05. So it's with 95% confidence interval, we can say patients who received oral prednisone are gonna have sleeping compared to those who are receiving it IV.
Really okay. Get on to discuss.
In addition to starting the treatment with methylprednisolone or any other steroids, you can also, because we know vitamin D deficiency is one of the risk factors. So you can test for the deficiency, and if they are deficient, which I'm sure they are, the patients are, everybody is, those who have MS, start them with vitamin D supplementation. Yes, it's available over the counter, but it might not be a therapeutic dose. So you have to prescribe it, tell the patients that they have to take care of themselves in terms of moderate, intense aerobic activity, because that has been shown to positively correlate with the betterment of the patient. If there is a smoker and if you say stop smoking, of course, nobody's going to listen to you, but still you can have them on some smoking cessation plan. Maybe tell them, okay, cut one cigarette. If you have I don't know, I never smoked, so I don't know how many cigarettes are there in a pack, but whatever they are, you can tell them let's say if you smoke 10 cigarettes a day, take one cigarette off, do 9, and try, and that should be a baseline and work. And of course, if there are any coexisting conditions, you have to treat for them. That's what you can do. And after that, you have to make a referral to the neurologist, and the neurologist will take care of it. So let's look at glatiramer acetate, which actually came in 1996. It was a breakthrough drug. Why it is breakthrough? Because the composition of glatiramer acetate resembles our own myelin sheath. Remember, myelin sheath is the one which is getting destroyed by mediators. So now we have a drug resembles a myelin sheath. So what it does, it tricks our inflammation. It cannot get into the blood-brain barrier. So it stays in the periphery. When it stays in the periphery, all the inflammatory mediators think this is the myelin sheath. They can be tricked very easily. So we are actually tricking them into believing that glatiramer acetate is actually the myelin sheath, which it is not, and it cannot go through the blood-brain barrier. So whatever the inflammatory mediators are there in the blood, they come out of the blood from into the blood and go into the periphery, and they attack glatiramer acetate. And now we have enough time for brain to undergo remyelinization. Are you getting my point here? It's very unique because it resembles the myelin sheath. The composition of this drug, it resembles the myelin. Since this drug cannot get into the blood-brain barrier, cannot get into the brain, it is in the periphery. Once it stays in the periphery and the inflammatory mediators, which are migrating towards the brain, they see it on its way. Oh, here we don't have to go that far into the brain. We can target it right. And as a result, it distracts the inflammation. And now the brain is free of the mediators, and now it can undergo a process of remyelinization. It's a very effective drug in preventing the relapse. Very effective. I've already explained what is there on the slides, but you can feel free to look at it. Sorry, the language that I've used is pretty much what we see on the board examinations in the United States. You don't have to read that, but the PowerPoint was made for the residents here, so I'm using the same PowerPoint. Oh, okay, so here are some pharmacologies. It is given subcutaneously, so the site of injection can be arms, abdomen, hips, and thighs, but it is not like your Ozempic. You know Ozempic, right? Everybody all over the world are using for weight loss, but it's an anti-diabetic drug. Which patients self-administer themselves, but this is not that drug. You are not supposed to allow the patient to take it home and administer it themselves. You should administer it. Why? Because it has significant safety concerns. It is used for all kind of MSs. Doesn't matter if it's a clinically isolated syndrome or it's a relapse remitting, secondary or primary progressive. And it can be safely administered in pregnant patients. It's not teratogenic. Dosing I mentioned dosing here because, as I said previously, I actually gave this lecture for the neurology resident students. So they treat patients, so they needed to know how much they have to start with. Let's look at the adverse effect because they are very significant. You will see lipoatrophy, which means once you administered it subcutaneously, you can clearly see sometimes, at least in less than 1% of the patients also send them out. If less than 100,000 patients and 1% of them, how much it is? So they can cause visible dent. So what happens, the fat, the subcutaneous has lipids in it, they become atrophied. And that results in the denting, which looks from the physical if you look physically examine it, it looks like a dent. But more than 10% of the patients can also have fevers, chills, and aches. So you must prophylactically treat them with, let's say, NSAIDs or acetaminophen. Some people can develop episodes of flushing, diaphoresis, dyspnea, and palpitations, but they usually resolve in 30 minutes. But somebody who has a history condition, you should do a baseline EKG
You does-
first. Otherwise, it can cause um, arrhythmias. Let's look at another category of drug, interferon beta. As I was telling you earlier, interferon gamma is the one which is pro-inflammatory. Interferon beta is anti-inflammatory. So it's absolutely opposite. It blocks the action of interferon gamma, and that is how it reduces the inflammation and the immune reaction which is going on in the CNS. There are 5 different drugs that we have currently in interferon beta category. We have interferon beta 1A, B. 1A have been shown to decrease frequencies of relapses, but they do not contribute to the decrease in the severity. Beta 1B, they can reduce the severity and they can also reduce the frequency of relapse. There is a warning here. So patients who have some psychiatric history, for example, some has depression or bipolar or have suicidal ideations, you really have to be careful administering to them. And if somebody has a suicidal tendency, what are you going to do? Electroconversion therapy. I know it's inhumane, is the DSM-5 standard procedure. Injection site necrosis happen. So if you're on this drug and the patient, let's say they have some sort of hepatitis or they are on statins, most people have cholesterol issues. And if they're on statins, statins can also elevate your LFTs. LFTs mean liver enzymes, transaminase, alkaline phosphatase, GG, those. That means they're exacerbating the liver pathology. So liver can be damaged. So if you have those patients, you have to do a baseline LFT test. Because first, get the liver tested, see how elevated the enzymes are, and because you don't want to be treating people one, you are literally encouraging the development of another disease. You don't want to do that. Similarly, those patients who have hyper or hypothyroidism, they're also at increased risk of developing exacerbations. Seizure risk is there because it reduces the threshold for seizure, so you can have seizure. So it's always good to have a prophylactic treatment given that they have a neurological history. There are other minor adverse effects like symptoms, visual disturbances, fatigue, and headache, which can be dealt with very easily. That is why I have tabulated in such a way which clearly shows the warning sign that you have to monitor and what are the minor facts. Avonex, betaferon, Extavia, Plaquenil, these all are interferon beta. Are we good with this? Okay. Let's look at sphingosine phosphate receptor modulator. So what are sphingosine receptors, first of all? That is the primary question. Once you know the receptors and their role, then obviously it's very easy to know, okay, these are the targets that we have our drug targeting. So these are the receptors which are all over literally in all the immune cells, you name it, whether it's neutrophils or monocytes or dendritic cells or eosinophils or natural killer cells, whatever they are on the surface membranes of all these immune defense mediators. What they do? Well, they help in the process of inflammation by recruiting those mediators, and they can cause fibrosis. They can help in so generally it's a good thing. I'm not saying these are bad here. No, they're good receptors because in an individual, these are the things we need to help control the infection or control, whatever the invading organism is. But things are flipped when you have autoimmune. Means body is now treating as if it's a foreign thing and attack. So that is why these receptors need to be blocked. We don't want these receptors, and that is very specific, targeting these kind of receptors 1, 3, 4, 5. we have these drugs, fingolimod, ozanimod, and ponsanimod. So these all drugs are very important, very specific, but again, they are used specifically for relapse remitting. Let's look at fingolimod. This was approved in 2010. We have ozanimod, and then in 2021 we have ponesimod. Fingolimod, as you can see, it's common, so it's very non-selective. It can bind to all kind of sphingosine receptors, 1, 4, and 5. It doesn't bind to 2. Not have any drug that targets 2, by the way. Then we have drug which is specific 3 and 5. Siponimod can target 1 and 1, 4, and 5. It does not target. And ponesimod only targets R1. Just to recap what these receptors are important mediators. They are present on the inflammatory mediators. They are present on our defense mechanism system, neutrophil, for example, or dendritic cells. They're good in normal situations. Abnormal situations such as manifested in conditions, we need to prevent these receptors from doing their job. We can block them by using these drugs. These are the new categories. As you can see, the first drug category was approved in 2010. Let's look at specific characteristics. They're specific, but it doesn't mean they do not have adverse effect. So fingolimod can be administered to patients who are 10 years or older, but not below that, because the risk of damage is too high. You have to watch out for the heart because it can cause bradycardia in a matter of, as a matter of fact. So you want to make sure that the patient is in optimal cardiac status, perform a baseline electrocardiogram, which we call EKG, for liver damage. So you have to do LF. And people who have macular degeneration or some sort of ocular disease, it can elevate the intraocular pressure. And but it's not right away. That's something which you see within 3 to 4 months. So you can taper the drug off or you can titrate it down. Hypertension can affect significantly if you suddenly discontinue. If you're not discontinuing, if you're weaning the patient off it, then you might not see hypertension. If you suddenly drop it, you will see hypertension. For those who are pharmacy students here, you remember with the steroids, what do you have? And deficiency, which can be very fatal. Similarly, hypertension can turn into hypertensive crisis, not just regular hypertension. And it is indicated in pregnancy. So if you're planning to become pregnant or if you're already pregnant, not a good drug for you, you can skip on Simon. Let's look at some more specific modern medicines, which we call monoclonal antibodies or antibodies in general. CD20 and CD52 have been known inflammatory mediators. So we have antibodies which target immune cells and block them. And when we block them, we do not have inhibition. So let's look at alemtuzumab. It's very specific for CD52. Ocrelizumab is for CD20, rituximab for CD20, and ofatumumab is for CD20. Just because I mentioned these drugs here doesn't mean they cannot be used elsewhere. They are used in other autoimmune conditions, in cancer patients also. For example, rituximab is primarily used, as a matter of fact, it was first approved for Hodgkin's lymphoma and non-Hodgkin's lymphoma. It is also used for leukemia patients, but subsequent research trials, clinical trials have shown their efficacy in treatment of MS patients. These are the key adverse effects. So if you're taking alemtuzumab, you might have thyroid issues, hyper or hypo, could be either one of them. Headache is treated well. Ocrelizumab, happy reactivation. So make sure you're vaccinated for it beforehand. If you are up with your immunization status, that's fine. Otherwise, there is a chance if you ever had any exposure to any hepatitis B infection in the past, there is a chance that once you're on this drug, it can cause the reactivation of that. Rituximab, you typically see the heart attack or arrhythmia, trouble breathing, these things. So always good to have epinephrine by your side. We call it EpiPen. Natalizumab is little different. It does not target any CD4 cells. It targets, as a matter of fact, alpha 4 integrin, which is important mediator in consolidating the plaque. And how does it consolidate the plaque? Well, it brings in the molecules such as laminin, collagen, and fibronectin, promotes the extravasation of the leukocytes, and they all migrate toward the plaque site and they further consolidate the plaque. The key adverse effects are not really good here. Progressive multifocal leukoencephalopathy. So you're treating MS, but you end up developing some other kind of CNS disorder. So it's not a good thing. That is why we now use rituximab or ocrelizumab or ofatumumab a lot compared to natalizumab. These are some miscellaneous drugs: teriflunomide, cladribine, fumarates, and delphampiridine. Teriflunomide is a pyridine synthesis inhibitor. So what it's doing is actually preventing lymphocytes formation. When lymphocytes are not formed, how can they be activated? When they're not activated, how can they do the autoimmune thing? They cannot do it. They are contraindicated though in pregnancy. Cladribine is a purine analog. It also targets the formation or the synthesis of lymphocytes, but it also triggers their apoptosis. So it is slightly better, but again, you cannot give in pregnant patients. You cannot give to somebody who already has autoimmune condition or is transplant recipient or has HIV infection. And also, it can cause mutation in the sperms. Who's planning to have children, they should, and if they have MS and they are on this drug, they should wait for the treatment to be over, wait for at least 6 months, and then you can plan the pregnancy. We have fumarates. We have two drugs in the fumarates category. Both of them, they activate the nuclear factor like 2, which reduces the inflammation and cytoprotection. Delphampiridine is a potassium channel blocker. It aids in the nerve signal conduction. The problem with this drug, though, it takes forever to work. 6 weeks is a pretty significant time, right? 6 weeks. It takes about 6 weeks to just kick in. And it's only useful for those patients who have difficulty walking, but it does not have any, let's say, it does not improve the mortality. It does not increases the relapse or remission time. Nothing. It just related to the mobility issue. So somebody who is having trouble walking, they can use this drug. Again, it lowers the threshold for the seizures, so the patient is at risk of developing seizures. Somebody who has a history of epilepsy or non-epileptical seizures, they should not be taking this drug. Or if they have to, then you have to give them a prophylactic treatment for those. Let's look at the drugs which are very specific for different phenotypes of the MS drugs. If it is clinically isolated syndrome, you can easily prescribe any of these 3 drugs: glatiramer acetate, interferon beta, or teriflunomide. Glatiramer acetate is usually prescribed because it is available. It's cheap, it's covered by the insurance, it's generically available. For rapid relapsing and remitting multiple sclerosis, you can use all the 3 drugs which are mentioned above. But nowadays, people use antibodies, ocrelizumab or rituximab. But you can also use fingolimod. You can also use dimethyl fumarate. Of course, these depends on what your patient presents with, what are their pre-existing conditions, and which drug suits which patient. But anybody who has RRMS, these drugs can be prescribed. For secondary progressive MS, though, all the above can be prescribed, but the most significant outcome that we have seen is the seponimod. They have been wonderful. They have literally done the magic for those patients, so to speak. Sipanimod has been clinical trial after clinical trial, whether it is Swedish, whether it's Denmark, whether it's even in India and North India, they did a clinical trial a long time ago. Or in the US, this is a drug for those who have secondary progressive MS. Primary progressive MS, ocrelizumab, was the drug which was approved in 2017. And that is the only drug you need to care about. You don't have to do anything because nothing works there. Remember, primary progressive is a very advanced and very aggressive form of MS. So this drug is better than the other, ocrelizumab. For pediatric patients, you can use all these drugs, antibodies including, but you have to lower the dose. You also have to do a complete blood count with differentials and liver function test. This is, I don't know if you want me to go over this or not, but this is an approach which is specific for the neurologist. So there are two types of approaches they take. One, they call it escalation approach. The other one is inductionist approach. It means pretty much this. Do you want to adopt an aggressive approach or you want to take a very conservative approach? That's what it is. Conservative with regards to the adverse effects. So are you looking for absolute control of the disease status? So it means you can go for the most effective drug, knowing fully well that it can contribute to significant adverse effects, or you want to play safe. It's up to you. In cricket parlance, if you want to hit for 6 on ball 1, or if you want to take 1 or 2s in singles, it's the same thing. So everything has its own pros and cons. Here is the data. Let's see if you appreciate this graph. So this is the high intensity approach, and this is the escalation approach. So high intensity approach, as you can see, over a period of 20 years, the disability index was less compared to the escalation approach. It's straightforward because they're high intense drugs. They are very good in controlling the disease status, but they come with a cost of increased adverse effects. Same thing. So this is a Swedish study in yellow, and this is a Denmark study. And they also said the same thing if you compare both graphs. The intensive approach resulted in better remission-free, progression-free period compared to those which had the escalation approach. This is the infection rate that we have seen. These are the 4 drugs that I just mentioned here, but there are many more that you can look up. But over the period of time, we found rituximab was highly successful in treating, but it had the highest incident rate of infections. Highest, 19.7% per 1,000 patients. 19.7% infection rate. The lowest was interferon and glatiramer acetate. And if you want to compare it